And
Okay.
it would be very good if you can pick his brains on what those guidelines did address and what they failed to address, what the future directions or the gaps in knowledge are. So would you please get started? I'm sorry to interrupt again.
Not at all, sir. I'll summarize the key messages that were released by the new ACC 2020 guidelines. The first key message is they emphasized on the shared decision-making between the patient and the caregivers. And we should discuss all the risk and the benefit of the diagnostic tools, the treatment options, and we should engage the patient in the process of the decision-making. They emphasized the role of the multidisciplinary HCM centers and how it changed the management and improve the outcome in the different modalities of treatment. They also given attention to the counseling of the patient and screening of the family members. They also given attention about the role of the cardiac imaging, especially the echo and CMR, to confirm the diagnosis and to help us in the risk of stratification of the sudden cardiac death. Also, they give a big part for the individual patient risk for sudden cardiac risk assessment, and he should participate in the decision making regarding the ICD placement. They also give an attention for the risk of sudden cardiac death in children, as this group of patients are to some extent few in number, and they should have a special way of management. And the most of the decision in this age group regarding the ICD placement usually follows the expert opinion. Also emphasized the role of self-reproductive therapy that should be done in experienced HCM centers. They emphasized the effect of the atrial fibrillation and the bad outcomes of the atrial fibrillation in HCM patient, and they emphasized, as you know, about the independent, the anticoagulation independent of the CHA2DS2-VASc score, and the importance of the maintaining of the sinus rhythm. They stated that the patient with non-obstructive HCM who have heart failure symptoms should go for guideline-directed medical treatment as per the heart failure guidelines. And finally, the 10 key message is about the exercise and the recommendations for exercise. They stated that patient with a stable HCM can go for moderate intensity exercise. However, if HCM patient wishes to go for a vigorous exercise, this should be after a shared discussion between the patient and the caregiver. And the patient should know that we cannot individualize the risk for a given patient regarding the exercise. Do you want Sir Piri to give a general comment, or shall I go for each specific item and say what was the new updates?
Maybe Professor Elliott can give us his view about what has just been said.
Yeah, so I think the 10 points that you've just gone through summarize the current guidelines very well. I mean, I was, as you know, I chaired the 2014 ESC guidelines, and I was very privileged to sit on the US guidelines. I think one of the key messages for me, which isn't on that list, is that we're seeing convergence. So there have been a lot of artificial divides created between the European view and the American view. In fact, most of those differences were synthetic. And I think what we're seeing in the current guideline is convergence of most of the controversies that there have been in this disease. I think for me, the most important things that have come out of this are the importance of exercise, because I think this is a disease where patients have been forbidden to exercise to any degree, largely because of a medico-legal concept rather than because of any evidence. And I think this is an important step, particularly for the US, to accept the fact that some patients with hypertrophic cardiomyopathy can exercise, not to great intensity, but to a level which maintains their overall level of cardiovascular fitness. So I think this is a really important step forwards for the guidelines. I think the other thing, which perhaps I'll leave until we get to the sudden death issue specifically, but there remain some differences of emphasis between the ESC guidelines and the US guidelines. But in essence, it's about systematic evaluation in every patient to estimate their risk. I think one thing that the US guideline has pushed forward is this move away from specific cutoffs, which is something that we do all of the time in guidelines. You know, if you meet this threshold, you do A, if you don't, you do B. And I think the US guidelines have said, look, life is not that simple, and that there's no sort of single definition of an acceptable risk. So there needs to be a more dynamic dialogue between the physician and the patient. And I think that's something which I think, certainly for the next iteration of the ESC guidelines, I think we'll think about incorporating. But please go on. I think we can deal with the issues specifically as we go through.
Okay, sir. Regarding one of the most important parts in the evaluation of the HCM patient, which is the risk stratification of sudden cardiac death, we can see on the left the 2011 guidelines, the American guidelines, and on the right the 2020. And we can appreciate it's very known that patient with prior cardiac arrest should go for ICD insertion, and there is no disagreement, or there is agreement on this in both guidelines and even in the 2014 guidelines. Regarding the other risk factors, there is a changes in which the apical aneurysm and the ejection fraction less than 50% were added to the new guidelines, and they recommend to be used in the decision regarding the ICD insertion. These two items were not were present before as a risk modifiers. While the family history of sudden cardiac death, massive LVH, unexplained syncope remained the same between both guidelines. The second change that is very important is they omitted the abnormal blood pressure response from the 2011 guidelines, and they downgraded it in the 2020. Also, the third change that the importance of the extensive late gadolinium enhancement on CMR, it was present before as a risk modifier, but now they went for more specification and the more quantification of this item per se. They stated that presence of 15% of the total LV mass of the myocardium, including the late gadolinium enhancement, this is a risk factor and may be considered for the ICD insertion. And this is the guidelines that we said it's a class 1 indication to consider the major risk factors that we just said. Going to the on the other hand, the European guidelines is, as you know, is to some extent is different and has differences regarding the versions of the AHA guidelines. Regarding one of the differences, or some of the differences, are the inclusion of the age. The age is present in the HCM risk sudden cardiac death calculator. It's not present in the American one. The maximum LV wall thickness in the European guidelines is a continuous variable, while in the American it is binary marker, which is meant less than 30 millimeter is not considered a major risk factor. More than 30 is considered a major risk factor. While in the European one, no, it's a continuous number. Continuous number means that 20 millimeter LV wall thickness has a less weight in the decision making than 30, but it has a weight in the decision making. Also, the left atrial size is not present in the American guidelines, and the LVOT gradient is not present at all in the American guidelines. It is in the calculator, while the other items are present in both guidelines. Here, as you see, regarding the leg gadolinium enhancement is what it was a class 2B and still class 2B, but they stated that the number of 15% as a cutoff for suggestion of the risk of sudden cardiac death. However, there is a major challenge in the leg gadolinium enhancement quantification, which is the methods of quantification. We have about 6 to 7 methods of quantification of leg gadolinium enhancement, and there is no agreement on which method to use in this regard. In the 2020 guidelines, they stated and they reported the importance of the HCM risk sudden cardiac death calculator, and they recommended to use it, but they stated clearly that it's not used as alone in the decision making regarding the ICD insertion. Do you want, sir, Prof. Yaqub or Prof. Elot to comment on this item? The role of CMR in the risk stratification in this patient?
So, thank you for that description. So I think just as a first general principle, assessment of sudden death risk in hypertrophic cardiomyopathy, it's sometimes presented as a mysterious art. But it's simply an assessment of the severity of the substrate. So how bad is the heart? And everything that we look at, whether it be wall thickness, whether it be non-sustained VT, whether it be left atrial size, whether it be family history of sudden death, which is a surrogate, if you like, for the genetic substrate, these are just telling you how bad the heart is. So if you've got a really bad heart, you're going to have more of those things. That was, if you like, the basis of the previous semi-quantitative way of assessing risk. You take it, this list of risk factors, and the more that you have, the greater is the risk. In the 2014 guideline, what we wanted to do was to make that more quantitative, so you could actually have a more intelligent discussion with the patient. So rather than just saying, well, you've got this risk factor and I think you're at risk, I can say, well, on the basis of data from, which is now about 8,000 patients, I think, my estimate for your risk in the next 5 years is X%. Now let's have a discussion about what that might mean for you. And what is my view? What is your view? These risk factors in the model were not random. So these were selected from the literature as being risk factors which have been shown to be an independent predictor of risk. And that's why blood pressure was not used in the ESC guideline. Because whilst abnormal blood pressure response is associated with risk in younger patients, it isn't an independent risk factor. So that's why it was deliberately omitted, because it didn't meet the a priori criteria for selection into this. Whereas left atrial size, gradient, age, which you emphasized, is fundamental, because non-sustained VT when you're 19 is not the same as non-sustained VT when you're 65. It has a completely different meaning. What was missing from this, which is something that we do in practice, but I think which is perhaps being addressed in the American guideline, is left ventricular function. And I think that, for me, is the remaining missing risk factor in this approach. Because you can, if you tot all these things up, if you've got an ejection fraction of 35–40%, then you are at higher risk of dying suddenly. So we actually use that clinically as the unofficial risk factor, if you like. I think if you go to the US, the new algorithm, for me, this is essentially taking the old paradigm of 1, 2, 3, 4 risk factors and just updating it. I was the only European on the guideline, so there were some interesting discussions going on when we did this. For example, non-sustained VT. Non-sustained VT has been debated for 30 years as a risk factor. And the response is, yeah, how can this be a risk factor for sudden death? Well, it is the most consistent, reproducible risk factor for sudden death. So that was a big battle to get that acknowledged at all in the new algorithm. other legends are what I think you've got a slide which says, well, it would be reasonable to say that if you have multiple runs or long runs of non-sustained VT, that's worse than a single run. There is zero evidence to support that. Zero evidence to support that. All the evidence suggests if you have a run of 3 or 4 beats, then that is all you need to consider it as a risk factor. If you go to the American flowchart, I think for me a personal triumph was to get the ESC guideline, the risk model acknowledged, but you've got to look really hard for it in this diagram. So if you look at the second box, at least one of the following, it says yes, and then there's a small annotation there that refers to the ESC guideline. So you've got to first of all you've got to see it, and then you've got to go to the text, and then you've got, but that came from someone on the committee. So I've probably broken all the rules of confidentiality already, but somebody on the committee who said, look, I want you to take this approach, but if there's a tool out there which quantifies my risk, I want that information as well. Now the disagreement is, what do you do first? Do you do the risk estimate and then look for other risk factors, or do you look for all the risk factors and then measure the risk? I know which way I would do it in my practice, but the basic principle is still assess the phenotype, assess the family history, and then try to collate that information into an estimation of risk. The gadolinium story remains, so for me the story is the same as it was in 2014. There are individual studies out there which show that the more scar you have, the higher is your risk. And I have no problem with that as a concept. It makes perfect sense because the scar is one of the substrates for ventricular arrhythmia. The problems are that measurements vary enormously for the reasons you pointed out. You have different techniques for measurement. 60% of patients with hypertrophic cardiomyopathy have GAD. So, depending on how you threshold it and how you report it, you could end up putting a lot of ICDs in totally unnecessarily based on inappropriate or incorrect assessment of the amount of scar. And it still hasn't been shown to be an independent marker for risk. Now, you're probably aware there is an ongoing international study at the moment called the HCMR study, which is attempting to resolve this issue. But the study's been running for 5 years, and it still hasn't seen enough events to be able to say that scar is associated with risk. So it's not the most powerful risk factor. And with any my final point, sorry, I can't help but be evangelical about this point, but my final point about scar is like any biomarker. You have to say of a biomarker, what does this tell me that I don't already know? And GAD tracks with wall thickness, it tracks with non-sustained VT, it tracks with left atrial size. So is it telling me something fundamental that I can't pick up by using these other tools? And at the moment, I think the jury is still out on that one.
Professor Elliott and Professor Yaqub, so I'm glad that Hosni started with the hot topic, probably. But I've sort of always wondered about 3 topics. Why weren't they considered? One of them is sort of standard functional capacity. So functional capacity has been at the heart of risk stratification in almost every cardiovascular disease. I haven't really had the pleasure of digging deep into the data, but I've always frowned upon how come this did not translate into one of the logarithmic factors to look at. The 2 other factors were essentially biomarkers, as you quite rightly mentioned, was BNP and any surrogate for coronary flow reserve. So again, they're different. One is very simple. One is readily available with BNP. One will require some sort of fancy technique, be it invasive or non-invasive. But have those been factored in? What exactly are the data?
So I think they're all brilliant suggestions. Again, to put them into a sudden death model is very challenging because sudden death rates in HCM are very low. If you look at the composite of a sudden death and an ICD discharge, it's about 0.6% or less now per year in a large HOCM population cohort. So this is the challenge that the MRI community are having. In order to be able to conduct a prospective study to examine the association between GAD and risk, they're having to study 4,000 or 5,000 patients for a minimum of 5 years. And for each of the things that you've suggested, that hasn't been done, and it will be challenging to do prospectively. That said, for the first two that you mentioned, there are decent-sized cohort studies examining, for example, peak VO2 and risk, N-terminal pro-BNP and risk. We've published on this ourselves. And what appears to be the case is that both of those track with all-cause mortality and heart failure endpoints, but not with sudden death endpoints. So they're very good at describing the heart failure phenotype, but not the ventricular arrhythmia phenotype. Microvascular dysfunction, I did my thesis on ischemia in HCM, so I have a soft spot for it. The trouble with microvascular ischemia is it's a damn difficult thing to measure. And there's also this difficulty of heterogeneity in flow and metabolic ischemia. And what people have done in the past is to extrapolate what we know from coronary disease to hypertrophic cardiomyopathy, which I think is probably an inappropriate thing to do. So if we had a really good, easily measured surrogate for ischemia beyond troponin, but something which tells you about ischemia rather than necrosis, that would be, I think, a way of answering your third point, I think.
Thank you. Professor Yaqub, you've always placed some weight on LVOT obstruction, particularly in children and adolescents. So I remember discussions when there was sort of the gray zone, both in terms of going through the risk calculator properly and in terms of identifying different risk factors for sudden cardiac death. And your impression was, given the lifelong difficulties associated with an ICD implant in an 8-year-old kid, removing left ventricular outflow tract obstruction might substantially help that. And in all honesty, the data we have in our registry to a great extent supports that in younger individuals. What is your take on that?
Thank you, Ahmed. I think 2 points here. One is that children, or HCM in children, appears to be a different disease. And I would like to hear from Perry about what he thinks about that. So what we can apply to adults is not the same for children. I feel a soft spot for children, and I feel we don't know enough about how to behave with the children, and if they are vulnerable, they are more sensitive, etc., etc. And the disease is different. Sometimes they behave much worse, and sometimes they behave better, and therefore to take a less aggressive approach and test the hypothesis, which has been actually validated to some extent in a New England paper about getting rid of the obstruction, actually is something which can at least improve the incidence of both mortality and sudden cardiac death in particular. So that's my take on that. Your other point, which the exercise capacity and the quality of life. Those are two parameters which I sort of like, not just emotionally, but I think that I attach a lot of importance to them because they are independent, objective methods of what Professor Elliott mentioned, severity of the disease. So I want to know how incapacitated this patient is, and their description sometimes is not enough, and I want a more objective evidence as by those two criteria, either something as simple as 6-minute walk or formal exercise capacity with VO2 max. If you have it, that's great. And the last one, which I think is really important, is so-called quality of life, because the patient might not elect to tell you everything. You have to extract it from him. Thank you.
Okay, sir.
Matt,
Thank you for your...
Actually, sorry to interrupt.
Yes, sir.
Just to emphasize that last point that you made, Magdi, I think the quality of life issue is even more important now, I think, as we move into an era of randomized trials in hypertrophic cardiomyopathy. because it's going to be very difficult to construct trials with hard endpoints. So we're looking for a reproducible and meaningful functional endpoints. And I suppose the first real insight into that concept is the recent mavacamten trial, the Explore HCM trial, where we saw dramatic effects of the drug on peak VO2, on KCCQ, and a specific HCM risk, quality of life score. So I think assessing quality of life is going to become fundamental, I think, in therapeutics in this disease. The second point that you discussed, which I think is fascinating about obstruction in kids, I think kids and adults are different. A signal that has been happening for the past 5 years in outcome studies in kids is that the presence of obstruction seems to be associated with a lower risk of sudden death. And that doesn't make any sense to me. And I think it's because those kids are getting surgery. And that hasn't been factored in to the outcome studies. So my colleague in London is working with a consortium now to specifically look at this point to in a way sort of validate your clinical sense, which is that getting rid of obstruction in kids is a good thing to do. I think it probably even more so in kids than in adults actually, but work is underway to try and prove that.
Okay, may I have a question, Dr. Perry? I am Karim Saeed. As you said, one of the limitations related to the European risk calculator is the tendency to have the risk as white or black as a cutoff.
Yeah.
But the same applies to the American guidelines when we look to the definitions of the major risk factors.
Yeah.
Whether 30 millimeter cutoff for wall thickness, 50% ejection fraction, 15% lead gadolinium enhancement. And this carries a limitation related to the method to evaluate such not these accurate endpoints. And it is a continuum as well. What do you think about this?
Completely agree. I mean, that was one of the reasons why we tried to develop the risk tool, to get away from this crazy binary idea. You know, Mr. Smith, your wall thickness is 31 millimeters. I think you need a defibrillator. Mr. Smith, your wall thickness is 29 millimeters. Good news. You're okay. I mean, why do we do that? Why do we do that in medicine? It's nonsense. It's complete nonsense. It's pragmatic, and you have to choose a threshold, I suppose, sometime. But that's why we want to quantitate as much as we can, and then you have a number, and then you can talk around that number. And I still think that's the right way forwards for this and other diseases. I mean, the example you have on the slide. So, that patient, that example.
Oh, okay.
Sorry, we're holding you up. I know you've got. But if you go back to that worked example. So look at this. Risk of 5 years, 19%, 20%. Now, why is that? You've got someone who's got a wall thickness of 31. Okay, so that's quite severe. Left atrial size is a little big, not huge. Outflow gradient's 120, but
the age.
It's the age. It's the age. It's the age and the VT combined with the, if you like, the morphological substrate.
Family history of something called this.
Yeah. So if you were to change that to 60, it would probably still be high, but it's going to be nowhere near 20%. So yeah, age is a fundamental modulator of all of these things.
Okay. Going to the next point in the guidelines, which is the septal reduction therapy. There is no huge change in the concept of the septal reduction therapy or the methods. Just to comment that they stated that the patient who is, it was in 2011, it was stated that the patient who is not responding to the medical treatment and is still highly incapacitated should go for septal reduction therapy, and this should the patient eligible for this intervention should have the clinical indication, the hemodynamic indication, and the anatomic indication. Many of the patients may be incapacitated class 3 to 4 and may have a dynamic LVT obstruction more than 50, but the septum is 1.5 or 1.4 So the rate of complication will be high for this patient. So the three of the requirements for the intervention are important to be elucidated. There is no much change in the guidelines, and still the surgical myectomy is preferred over the alcohol septal ablation. Alcohol septal ablation is left for the patient who have a high surgical risk or have an advanced age or comorbidities. And as you know, each of the procedures for the septal reduction therapy has a pros and cons, and each one has, as you see, pros and cons. Regarding the surgical myectomy, it has high clinical efficacy and high success rate. However, it is more invasive and has a more surgical wound, and it is it's preferable to be done in the high experience center, while the alcohol septal ablation is less invasive with comparable reduction of the LVT gradient, but has a high rate of pacemaker dependency and pacemaker insertion. At the end of the day, we have a lot of challenges regarding a choice between these two these options. For example, the logistic issues that make the patient go in one direction rather than the other, and suitability of the anatomy and availability of the technique in each country, the availability of the expert to do the procedure, and at the final, the patient preferences should be taken into consideration. One of the new recommendations in the 2020 guidelines in comparison to 2011 and for the European guidelines, which is they recommended the patient with NIHA class 2 to go for surgery if it will be done in an expert center, and if they have one of the following complications as severe progressive pulmonary hypertension, left atrial enlargement, and symptomatic atrial fibrillation, poor functional capacity, and if the LVT gradient is more than 100 millimeter mercury in children, they can go for surgery and septal reduction therapy while they are in NIHA function class 2, and not necessarily to be highly incapacitated as stated before in the two guidelines. Another thing that be added in these guidelines, in which the patient have an apical HCM. For patients with apical HCM who are incapacitated and have great symptoms, they can go for apical myectomy. And there was one study that recommended, and one was done upon the apical myectomy in these patients, the patients who have severe mid-cavitary obstruction and highly incapacitated. They did the apical myectomy, as you see here. This is a patient with apical and mid-ventricular hypertrophy, and this is after surgery, the other picture. And this in this diagram, they we can see the line of myectomy that can be done for this patient. In this study, which was done between 1993 and 2017, 113 symptomatic patients with apical HCM underwent transapical myectomy while waiting the transplantation, heart transplantation, and they were compared to the patient waiting heart transplantation, and there was a survival benefit for apical myectomy in this patient. This is the new recommendations in these guidelines. Hoping to hear from you, sir.
Okay, so I mean, really interested in Magdi's comments about this, but I think for the first point you make, where the threshold for intervention has been down a bit, I agree with that completely. I think it's I think in retrospect, we were far too conservative in the 2014 ESC guidelines. But I think if you have class 2 symptoms plus the other features that you described, where the quality of life issue is important, and sometimes the quality of life relates to the disease, sometimes it relates to the drugs, because some patients do feel terrible on beta blockers, not surprisingly, because the only way in which you can increase your cardiac output if you have HCM is usually by increasing your heart rate. So you immediately reduce their peak VO2 by 20% by putting them on a beta blocker. Diazepyramide is a dirty drug. I mean, you can't see, you can't pee, you can't do various other functions. So it's the drugs themselves, the side effects can be pretty horrible for patients. So I think having a lower threshold for intervention is important, with the caveat that it needs to be in centers that know how to do the procedure. We already know from US national data that the mortality rates outside such centers is high for myectomy. So it has to be done by people who know what they're doing. The apical myectomy thing, that scares me a little bit, if I'm honest. So my gut feeling worries about carving out lots of muscle. I mean, Magdi, I'm sure you've seen it over the years. Some surgeons get a sort of Michelangelo complex where they want to sort of reconstruct the ventricle in their own image. And I think you're taking away functional myocardium. It may be thick, but it's functional. The other thing I would say is that whilst these patients, they seem to be doing better, there's still about a 5 to 10% mortality at 4 or 5 years in the ones who've been operated on. And that, in my experience, is very high for apical. Yeah, apical patients can be very symptomatic, but they live for a very long time with those symptoms. That is actually the challenge I encounter all the time, is that you've got someone who's got a poor quality of life, but they're going to have it for 15 to 20 years. They don't have this very high progression to heart failure. So I don't know how representative this was. And the thing that worries me about promotion of this as a technique in the guideline is that, again, you'll get inexpert surgeons doing this. You've got to have access to VADs. Some of these patients will end up being transplanted after surgery. You need a pretty top quality heart failure management transplantation team to do this kind of surgery. But that's a scared cardiologist talking. I don't know what Magni's view is of that as a procedure.
I share your view in a big way. I have a jaundiced view of apical myectomy for several reasons. I think it is destructive. You cannot see very well the trabeculae joining the papillary muscles, and you can damage the papillary muscles. The amount of muscle removed from, unlike the controlled fashion you do coming from the outflow tract, apical myectomy, to my sense, it's really a disaster. And I do not subscribe to the view that let's be aggressive and go through the apex. I have done it and don't like it and don't want to do it ever again. We need to develop other techniques where we can see better inside the ventricle. And that's not impossible through the outflow tract, and then see the papillary muscles, see which trabeculae, and mobilize things, as well as there are in the outflow tract, apart from, we're talking about the apical now, the fusion of the trigones, the presence of accessory muscle bands and all sorts of things cannot be appreciated from the apex. So I'm not a fan of apical myectomy, and I share your views there. About the indications for surgery, the two things I've always maintained, that looking at phenotype by imaging is really important. So you have a patient who gives you, he has some symptoms, and you say, oh, but the gradient is 30 and not 50. but you look at the imaging and you see the outflow shutting almost completely. You see a certain amount of, a lot of fibrosis on the septum, and the whole thing looks anatomically and phenotypically really much more severe than a gradient of 20. And to be a slave to a figure, like you were saying, is crazy. So I attach a lot of importance to how it looks like and what the patient says. And I respect those two things. And indeed, we have the argument of why do we think that severe hypertrophy in hypertension is a disaster, but not in HCM? I mean, this is just doesn't make sense to me at all.
Absolutely.
Severe hypertrophy, if you can get rid of it, particularly if you have documented obstruction, or if it was aortic stenosis, you have no hesitation. But if it is HCM, let's talk about it. And we've seen that. Maybe you, Perry, you're not old enough to remember when we were fighting the battle of never touch a myectomy or a patient with HCM, because this is a muscle disease and it's not obstructive. And it took a long time for people to prove that it is obstructive and it has to be treated as an obstructive lesion. So that's maybe I have a slightly biased view towards surgery, but I think the evidence, I don't know what you make of this, Perry.
I'm happy to admit in public I do have a bias towards surgery, if I'm honest. I mean, I think because for all the reasons that you said, I think my starting point is exactly the same as yours. It's what is the phenotype? You know, how severe is the hypertrophy? Where is the hypertrophy? What are the associated lesions you described? Is there elongation of the anterior leaflet? Are there accessory connections? What is the position and size of the papillary muscles? It's too simplistic to say that these are simple choices. I mean, the illustration you have on the screen at the moment, these pros and cons, what's striking is the complete absence of any description of the phenotype. Because there are some phenotypes that are just simply not amenable to alcohol ablation. You need a surgical removal. You would need to remove the accessory connections. And you can't do that with alcohol ablation. And this is a debate we still have even within our own group, where the refrain is, well, let's just try it and see the alcohol ablation. Well, I said, that's no way to treat people. You need to treat them with the right intervention. Don't give it a go, because you know it's not going to work. I think alcohol ablation is safe now. I mean, I remember being there at the beginning of alcohol ablation, and it was a scary technique. 7 mils of alcohol. I mean, you remember our colleague at the with you at the Brompton. It was a much more aggressive, in some ways more effective technique, because you got a larger infarct. Now I think it's much safer, but less effective. But it's always about the phenotype first.
Okay, sir. Going to the genetic workup for the patient, just to comment on the types of the genes that we are doing for screening for the patient. We have 8 genes known to definitely cause HCM with more than 1,500 abnormal variants. And this screening usually identifies a disease in about 30% of sporadic cases and 60% of the familial cases. And we have a spectrum of the types of the pathogenicity of the variants, from benign variants going to the likely benign variants of insignificance, and the likely pathogenic and the pathogenic variants. This is an example for my colleagues about the pathogenicity and the genetic test of one of our patients. It is stated that we have a pathogenic gene in a pathogenic variant in a gene MYH7 gene. It's a missense variant, and this is the coding for the purine and the pyrimidines bases, and the abnormal protein and the site of the chromosome. And the judgment over the pathogenicity of the gene is done with a lot of factors that are present in this table. Going to the recommendations of the guidelines, we can go here. This is the HCM index case. We test the 8 genes for every patient, and we will find ourselves to have either disease-causing, likely pathogenic or pathogenic variants, or on the other hand, the variants of insignificance or the benign one. What is new for me is the regular re-evaluation of the variant reclassification. So many of the variants of insignificance may become with time pathogenic or likely pathogenic. So the regular re-evaluation of the variant should be done every 2 to 3 years. Regarding this limb, if we do not find the pathogenic gene, we can go for the another second tier, which is the metabolic, the genes coding for the metabolic diseases that can form HCM, which is called the phenomimetics and the phenocopies of HCM. And
What happened?
Muhammad,
Yeah, I think we lost Hosni there. Dr. Karim, do you want to step in at this stage? That's always good to have backup.
We always have a double.
So I suppose the guideline, this is very similar to the 2014. Oops, where are we going? Here we are. Hello, is everybody still there?
What are you doing?
yes, Professor.
I can hear you.
So the guidelines on genetic testing, I think, are very similar to the 2014 guideline. Additional consideration is the fact that when we do variant interpretation, you have to revisit the variants, because we have variants that are thought to be benign, which are then reclassified as pathogenic, and sometimes vice versa, unfortunately. And I think that's a more general concept about the application of genetics in clinical practice and in cardiology. One of the concepts, which it's not a disagreement, but I do react to the notion slightly of a hokum center. I mean, I know that's what you guys have created, but I think hypertrophic cardiomyopathy has some very specific issues that require expert teams. We've been discussing those this evening, but there's a more general issue about cardiovascular genetics, and you actually need experts in cardiovascular genetics. They should be cardiologists who understand variant interpretation, the application of tests, and in the future we'll have to understand about gene therapy and interventions on specific mutations. And there are opportunities within hypertrophic cardiomyopathy, but there are even more opportunities within other genetic heart muscle diseases, and in particular dilated cardiomyopathy and arrhythmogenic cardiomyopathy. So I think you want a HOCM team, but I think a HOCM team within a cardiovascular genetics group, for me, is the way forwards for these kind of diseases. But I think the approach that's outlined in the guideline is pretty standard, as long as there's somebody in that heart team who's informing other cardiologists who don't necessarily need to have a lot of genetic information about the validity of the findings that they get back on a report. Until recently, I mean, I was at I did one of these a few days ago, and Bill McKenna was on the call. And we were musing over the fact that the first gene for hypertrophic cardiomyopathy was identified at the end of the 80s. And it's only now that we're really finding a clinical application of that. So its main role has been in family screening. And I think we've now got decent evidence to show that if you're a relative who carries the same mutation as the proband in your family, then over about 10 to 15 years, there's a 50% chance of you going on to develop disease. And as soon as you develop disease, you then become prone to disease-related complications. Mutation carriers who are male, who have abnormal ECGs, are much more likely to go on to develop the phenotype. What I want to try and do in the next 20 minutes. Mohammed, are you back?
Okay, I'm sorry, I lost the connection. Sorry.
I've tried to fill in for you as long as I could. So.
Thank you, sir. Thank you.
Professor Elliott, one question. Having someone on the team who has both the sort of clinical cardiology background and the genetic or clinical genetics background is a huge plus indeed. But you've repeatedly lectured on how the sort of paradigm shift and how we manage patients from a clinical perspective is sort of overdue.
Yeah.
And what we used to classify as rare diseases is not necessarily rare as such, and how we can be, as a matter of fact, missing a lot of clinical signs that only need sort of a pinch of salt on the genetic side to direct us to a completely different diagnosis. So, has that materialized over the past 3 or 4 years? And I'm asking that in a sort of skeptical way. And my second question is, so we've had some success with other training programs, for instance, hybrid training for cardiologists and surgeons for structural heart disease intervention or congenital heart disease interventions. But I'm not entirely sure that this has materialized in a proper training pathway.
Agree. Yeah. So, I mean, for your second point, we definitely need to be developing specific training programs for those individuals who want to learn about genetic disease, because genetic cardiology is not just heart muscle disease, it's arrhythmia, it's aortic disease. The genetics are fundamental to the paradigms for surgical intervention now for aortic disease. Cholesterol, it's across the field. Your first point about, is this happening? I think I do see growing interest amongst younger trainees and younger cardiologists coming through now, because this is, I think, seen as a really interesting new therapeutic area. I've been waiting for drugs to treat genetic disease for 20, 30 years now, but it's happening now. We're getting small molecule therapy, gene therapy is becoming realistic and not just science fiction. But I think a mistake that we've made from the cardiomyopathy community is that we go to meetings and we stand there like prophets in the desert, saying, but listen to us. That all these rare diseases, you're missing them. You will be damned if you do not find them. And of course, no one listens to that. All the heart failure guys go, here they go again. Yeah. Tell me about HFrEF, HFpEF, give me a trial. And I think we have to completely change the strategy. And the strategy for me is that the strap line for it, if you like, is hidden in heart failure. Because I think the heart failure community in particular have two legitimate questions. We keep saying this stuff is common. Well, first of all, prove it. And the second thing is, show me that it makes a difference making a diagnosis. And when you've shown me that it makes a difference, then I'll listen to you. And one of the catalysts to change is amyloidosis. So we have amyloidosis, which has always been there. Maybe as much as 13% of HFpEF, but no one was interested because it was a disease of the elderly and we don't have any drugs for it anyway. We just give them diuretics. But now we have specific therapies, and all of a sudden, there it is. It's all over the place. So what I've actually stopped doing now is using the word rare. I use the word actionable. And my hypothesis is that if you go to any heart failure clinic, and I'm focusing particularly on heart failure because I think that's where probably the greatest return is, you will find actionable diagnoses, whether they be genetic, whether they be inflammatory, whether they be infiltrative, that will have an impact on that individual or maybe for their family for some of the reasons we've touched on already. But we have to show that. We've got to prove that hypothesis for the world to change. And I'm going to try and do that before I retire. So
Okay, Hosni, you're back with us. Please go ahead.
Okay. So pathogenic or likely pathogenic variant. So we will go for clinical evaluation of the family members and no role for genetics in this subset of patient at the time of the evaluation of the patient. On the other hand, if we found a disease-causing likely pathogenic or pathogenic variants, we will go for cascade genetic testing of the all family members. And if we don't find if we are genopositive in the index case and we do not find the variant in the screened family members, so we can say for this genonegative family member that you will not have HCM in the future, and we can give him out of the follow-up in the clinic. While on the other hand, if the patient is genopositive, he should go for regular follow-up. Of course, in the post-mortem, in families with sudden unexplained cardiac death, we should go for post-mortem genetic testing. This is very important. Regarding the family, the timing of the family screening and when we should start the family screening. In 2011 guidelines, when the age of the family member less than 12, it was optional to test him or not to test him, unless there is one of the risk factors that the patient will have a bad outcome. While in the 2020 guidelines, no, they recommended that we should go for screening of the most of the family members, even if it is less than 12 years, at the time of the HCM is diagnosed in the index case. They also recommended that in the children or adolescent, we should not delay the family screening later than the puberty. Do you have any comments, sir, on this point?
Yeah, I think this is another important move forwards. I mean, again, I think we've been historically too conservative in the European guidelines. I think what we'd underestimated was the presentation or the presence of a phenotype in young children.
Okay.
So it's often there actually at birth. It's relatively mild, often doesn't cause problems. But Magda, you made, I think, a really good point earlier that, you know, in kids, sometimes it just seems to be nothing happens in childhood, whereas in other kids, they have a really aggressive course. And I think some of these kids who have early onset disease, you know, with hypertrophy and less than 5 or 10, they often, by the time they've reached their late teens or 20s, they've got horrible scarred ventricles, they're developing heart failure. So I think this focus on younger kids, I think, is appropriate.
Okay, sir.
May I have a question to Dr. Berry? Some HOCM, classic HOCM patients may have negative family history and the negative gene studies. And there is growing interest in this group, non-familial HOCM. Does this group has an actionable strategy to follow? And the other question is related, for how long to screen the first degree relative? When to stop screening? At what age?
Okay. Yeah, so I think, yeah, as you say, I think it's what we say, about 40% maybe we find a mutation, something like that. If you don't find a mutation in the proband, then the only strategy that you can offer to the relatives is periodic clinical screening, as outlined in the slide from the guideline. And the truth is that we don't know for how long you should continue to screen, but it is potentially for life. Because if you've got a late onset phenotype, then this disease can appear at any time. I mean, the oldest I've seen go from a normal heart to an abnormal heart was between the ages of 80 and 83 in someone who was carrying a known mutation. That pie though of where, you know, the proportion of patients who have a negative gene test is shrinking. We're finding in the past 2 years we've identified 3 or maybe 4 new genes, which account for maybe 1 or 2%, but you know, so that's 5%, say, or 6%. We've gone back and we've reanalyzed patients, and of course we're finding quite common intronic mutations. So if you look for intronic mutations in myosin binding protein C, that's maybe another 10% of patients. So actually, I think the number of patients who are going to turn out to be mutation negative is going to shrink. When I'm in the clinic, I do take my cue again from the phenotypes. So if the proband is a 75-year-old woman with an angulated septum, with a history of hypertension, with very localized basal septal bulge, I'm not particularly evangelical about screening the family, because I think that's a phenocopy probably related to aging and hypertension. Whereas if it looks like sarcomeric disease, this is what I say to all my fellows: if you look at the echo and you can't tell the age of the patient, then there's a high chance that that's a familial disease. So even if you don't find the gene, I would continue to screen the family. There are late onset phenotypes are not so rare. Myosin binding protein C is the classic, but we recently published a study in JACC looking at the expression of relatives with mutations that didn't have a phenotype at baseline. And I was actually very surprised, because it's basically linear in terms of the appearance of the phenotype with age. So I think you're potentially committed to a lifelong screening. How often? 2-yearly, 3-yearly? I think you have to do an MRI at some point during the baseline screening. Because again, another lesson which I've learned very recently is actually a surprisingly large number of patients will have a normal ECG. So the ECG, for example, is not good enough for screening.
I have a question, please. In somebody in the 60% where we don't find the mutation, particularly if there is a familial incident, what is the role of whole genome or whole exome? Should we subject all this group to whole genome and look for microRNA, non-coding RNA, all sorts of things? Should we or shouldn't we? It's a big endeavor.
It's a big endeavor, absolutely. So if we were able to use whole genome 5-10 years ago, we would have found all these intronic mutations in myosin binding protein C, which is about 10% of the disease. We've just submitted a paper on another gene, which is not a structural protein, but it's probably a kinase, which we think is maybe 3%, something like that. But we wouldn't have picked that up unless we'd done whole exome screening. Mm. So I think a minimum is whole exome. I think as we're still in this discovery phase, I think ideally, if it's feasible, whole genome, because I think where you have clinical testing and you have research testing, but in hypertrophic cardiomyopathy, we're still in the discovery phase. So I think it does have a role.
Okay. Going to the next point, which is very important, is the atrial fibrillation, with a very with the most common information or most important information that we should know, that the anticoagulation in patients with AF and HCM should be not following the CHA2DS2-VASc score. This is number one. And number two, the NOACs, there was a major change from the 2011 guidelines to the 2020, as you all know, for the great success of the NOACs in the management and anticoagulation of patients for different diseases. This is change number one in between both guidelines. In 2020 guidelines, they stated a term of subclinical atrial fibrillation, which is detected internally or externally by cardiac device. It's not symptomatic. The patient does not have a symptoms with a monitor more than 24-hour duration. While the clinical AF, the AFs that produce symptoms. They also recommended the anticoagulation for patients with more than 24-hour atrial fibrillation if it was subclinical. very important points that we should give a light on, which is the overall prevalence of the thromboembolism in one of the meta-analyses was 27%, and we have significant number of strokes observed in patients with a score 0. One of the important studies that subclassify the atrial fibrillation duration and give observations about the risk of stroke in this group of patients is the ASSERT study. The ASSERT study, they found in this observational studies that only episodes more than 24 hours of atrial fibrillation were associated with increased risk. Very short episodes lasting for a few seconds do not appear to increase the risk, and these patients need only continued surveillance. They found that when the CHA2DS2-VASc score of 1, increasing the risk of stroke only if the AF duration was more than 24 hours, and if the CHA2DS2-VASc is more than 2, episodes more than 5 minutes may increase the risk. This is a new information added to the new guidelines. As a conclusion, any patient with AF duration more than 5 minutes, if he should go for anticoagulation. If the patient have atrial fibrillation and HCM, and the atrial fibrillation episodes more than 5 minutes, class 2A to go for anticoagulation, and the class 1 if they have a more burden of AF and more duration of AF. Regarding the options of treatment of the atrial fibrillation, the result of AF ablation in HCM is less favorable than the patient without HCM, and most of the patient will go for repeat procedures and higher use of concomitant antiarrhythmic drugs. The surgical treatment of atrial fibrillation is very important. And many of the patients may undergo surgical treatment of AF while they undergo surgical treatment for the HCM as surgical myectomy. And the freedom of AF recurrence at 1 year was 44% in one of the studies for the surgical RF ablation, and the same was 75% in the MAZE procedure. We have a lot of medication. There is no major changes in the treatments regarding the maintenance of antiarrhythmic drugs, but I make your attention for the class 1C should not be prescribed for AF patient with HCM unless an ICD is present. The other safe options are sotalol, dofetilide, and amiodarone, duridaron in special cases.
I find sotalol to sort of have crept in a bit funny. I mean, especially with those with inpatients who are by definition hypertrophied. I'm not sure if that would be a first-line option. My second question, I don't know what the mechanism is. So why is it that we're seeing so many strokes in patients with a CHA2DS2-VASc score of 0? Is there an underlying explanation for that?
It's a really good question. So I think the common factor is atrial size. So it's, if you look at the stroke rate in HOCM and the AF rate, there's an exponential relationship with left atrial size. So if you're using just the parasternal long axis dimension, the inflection point's about 4.5. And as soon as it increases above 4.5, there's a dramatic increase in the risk of stroke and AF. There are other variables. So if you're female, you're more likely to get AF and a stroke. If you've got outflow tract obstruction, that modifies it a bit. If you've got heart failure symptoms, but the left atrial size is the critical thing. But there's, I think implicit in your question, I think there's another factor here. I've always felt that these patients with HOCM are much more likely to clot. So, I've seen people stroke within a few hours of going into AF. I'm very nervous about discontinuation of anticoagulation for the same reason. I've seen more patients than I care to remember who've been going for, say, pacemaker revision or whatever. And particularly, this is an issue possibly with the DOACs, and that the DOAC has been stopped, and then they have a stroke within 3 days. So there's a little bit of evidence, I think, back from maybe the 90s, suggesting that the milieu within the atrium is different, and that maybe they're a little bit more clotty. I don't really understand that, whether that's something to do with the endocardium, I don't know. But yeah, stroke is a real problem in hypertrophic cardiomyopathy. I think aggressive anticoagulation is entirely supported. And in fact, although I try to sort of imply it in the ESC guidelines, we actually routinely prophylactically anticoagulate patients with big atria, even if we haven't seen AF. Now, I can't defend that with evidence, but if your atrium is 5.5 or 6 centimeters, you're going to have asymptomatic runs. And I would actually anticoagulate the patient, even if I hadn't documented it. So I think this approach is entirely appropriate. DOACs versus warfarin, I don't know, but the die is cast. I mean, most patients are now being switched to DOACs. One of the effects of COVID in the UK has been that we've put virtually all of our patients onto DOACs because patients couldn't actually get INR testing during the lockdown.
There is another factor which I'm not sure how much importance does it play. With Philip Kilner, we have looked at the flow in the atrium and how beautiful it is with the effect of asymmetry, both on the right and the left, maybe even more on the left, where the pulmonary veins are entering in an asymmetric fashion so they don't collide. Now, in HCM, an area which has been neglected is the flow through the inflow tract. And right now, we have 2 of our biomedical engineers looking at that area. Because it stands to reason. The mitral valve is abnormal, and we just talk about outflow tract, and what about the inflow? And what is the effect on the atrium, the pattern of flow in the atrium? Should we have more studies addressing that really important issue? And what you were just saying, Perry, about are they hypercoagulable? I don't think there is evidence for that, is there?
Not
but
really,
the pattern of flow could be quite different.
Yeah, absolutely. I think that's a great idea because, as you say, you may have areas of stasis. Everybody focuses on the appendage, don't they? But actually, elsewhere within the atrium, you may have.
It is. I mean, if you look at the right atrium, and we have those beautiful things which was published in Nature and has been, people have quoted it more than 700 times or something. But the flow is something we ignore.
Yeah.
How can we?
Yeah, flow, atrium and ventricle actually. But
excellent point, Prof. Hosni, I'm hoping you can be quite graceful and wrap up within 5 minutes. Again, I'm very sorry we're keeping Prof and Professor Elliott.
Someone's just taken the turkey out of the refrigerator. So.
Yeah, I can imagine all the hallelujah going around you guys. I'm really sorry for that. So Hosni will be very generous and wrap up in 5 minutes. Please, Hosni.
Okay, sir. The last comment is that I want to hear from my dear professors is the exercise recommendations, because this is a very important point in the management, and it's an everyday question in the clinic. Should we go for exercise or not, and how to manage it? So what's your opinion, Prof. Perry?
Yep. So this is, I'm very open in my discussions with patients. I think this for me is the most challenging discussion I have with people, actually. But I have a very open discussion in that, you know, if you're a patient with a new diagnosis, everybody goes onto Google. The first thing they discover is this, you know, carnage amongst athletes dying from hypertrophic cardiomyopathy, and they're being told to do no physical activity at all. And yet, when you look at the data, patients with hypertrophic cardiomyopathy die suddenly either in their sleep or when they're doing mild exertion. This association between exercise and death in hypertrophic cardiomyopathy is weak. But as I say to my patients, the problem is that if I get a young fit guy who comes in with hypertrophic cardiomyopathy, what's going through the cardiologist's mind is, well, if I tell this guy he can go and run a marathon, he drops dead suddenly in court. I next find in the street, and I then find myself in the court, and the judge is saying to me, "So, Professor Elliott, you're an expert on this disease. This is a disease associated with sudden death during activity, I understand. Yeah. And you said it was okay for this gentleman to run a marathon. Do you think that was wise?" And it's the sort of thought that goes through cardiologists' minds. What we now have are data to provide some level of reassurance, I think. So, but Charlene Day in the US, she's taken high-risk cohorts, patients who have ICDs, and she's randomized them to exercise programs. And all that happens is that the patients who exercise feel fitter, do more, but nothing bad happens. They don't get more shocks, nothing bad happens. So I think sharing that information with an individual patient. I think Mohammed, on one of your slides, you had a line which was about individual responsibility, I think.
Yes, yes.
Yeah, which I think is another part of the discussion here. As a physician, what I can say is I think based on your assessment of risk and your morphology, I think you are at low risk from doing exercise. You're not zero risk, but you are at low risk. It's important for you to maintain cardiovascular fitness to reduce your risk of all the problems of being unfit. And then it's a joint decision with the person about exercise. So I think we can make it too complicated. As long as one is open and honest about the data, then I think you get around this issue. And I was really pleased to see this rather more pragmatic approach in the new guideline.
Okay, sir.
This what you have on the screen at the moment, I've never agreed with the ACC's list of sports, some of which are dangerous, some of which are not. I mean, come on, They always say that cricket is a low risk sport because Americans don't understand cricket. So, you can't divide it in that way. But I think assess the patient, do a risk assessment, and then you have an open discussion, and the patient themselves has to take some of the responsibility.
Okay, if you give me your last comment on the new pharmacological treatment is the mavacamten, with its new results in the new studies. What's your opinion? Yes.
So this is a really important study. It's the largest randomized trial we've ever had in HCM. It's a first-in-class drug, which is designed to target one of the fundamental pathophysiological abnormalities in HCM, which is this abnormal binding between beta-myosin head and actin, which is enhanced with some mutations. So you get this hypercontractile phenotype, this wasting of energy within the cell. What you've got with this drug is they started with obstruction because it's effectively a negative inotrope. So they had a number of easily measurable markers which could be built into a trial design. So you could demonstrate reductions in the outflow tract. And this was what was behind my point earlier on about functional endpoints. So they had peak VO2, they had KCCQ, and essentially overall everything improved with this drug. So the gradients came down, peak VO2 improved, which is a really hard thing to do if you think about what you're doing with this drug. The BNP came down, which is really good. The troponin T came down. So overall, very positive. So I think this is a very important moment, with some caveats. This is not a panacea. So, we've touched on several times in our conversations this evening about the fact this is a heterogeneous disease. It's all about the phenotype. And obstruction is about anatomy. So there are going to be some patients who are very amenable to drugs which reduce contractility, but there are going to be other patients who have a substrate where no amount of drug is going to improve the obstruction. So this is not, we're not going to dispense with surgery or alcohol ablation with this drug. The phenotyping is still going to be critical. There's a group of non-responders in this trial, and I suspect that relates to that group. The other thing is that as we roll this out into the real world, you're going to find some groups where actually interfering with actin and myosin binding may in fact be detrimental. So there's a small study come from Oxford, from Hugh Watkins' group, looking at patients who have troponin T mutations, which, the classical phenotype is relatively mild hypertrophy, disarray, a high risk of sudden death. But actually, that's a hypocontractile phenotype at the cellular level. And they've shown that giving mavacamten makes it more hypocontractile. So I think we will discover that there are subgroups of patients for whom MAVA is not the right drug. But this, I think, will be better than beta blockade. The only reason we use beta blockers is for tradition. And most of the time, they're not very effective in obstruction. So it's an important moment, but we move forwards, hopefully, but with caution, I think.
Okay, sir. Finally, I'd like to thank all of you, professors, and all my colleagues for your presence. And I'd like to give the take-home message that hypertrophic cardiomyopathy is a unique disease with special characters. The multidisciplinary team is very important, and should all collaborate to manage the HCM patient. The risk stratification for sudden cardiac death is still not sufficient and need more and more research. And in general, research in HCM is still growing and is still promising, as most of the recommendations are in the guidelines are expert opinion. So it's a very important area for research. Thank you for your attention.
Can I say something?
Yes,
now,
sir.
at this stage, it remains to me to thank Professor Elliott, who's been so generous with his time on Christmas Eve. And I don't know, I am speechless. Usually I am not speechless, but on this occasion, I just can't express my feelings towards Perry. Perry, thank you very much for your generosity.
It's very kind of you, Magdi. It was a great pleasure to do this. As you say, I'm an obsessive compulsive personality disorder. If you give me the opportunity to talk about HCM, I'll do it on any day of the year.
I remember that.
But thank you very much. I enjoyed the discussion.
Thank you very much.
Thank you.
Thank you, everyone. Merry Christmas.
Thank you. Thank you.
Cheers.
Merry Christmas, sir.
Thanks a lot, Ahmed. Thanks a lot, Professor Yaoub. Thanks a lot, all our friends, colleagues, Professor Karim Saeed, Professor Ahmed Al-Gendi, Professor Yaoub, Professor Elliott, Professor Mohammed Hosni. We learned a lot from all of you tonight, and we are glad and really honored to have you all on board, and Happy New Year to all of you.
Thank you. Thank you.
Cheers, everyone.
Bye.
Happy holidays.